And now time to go to next session. Dr. Walid, please lead the session.
Thank you. So I'm really enjoying this concentrated scientific content, and I think everybody's enjoying. So we will move to the next session immediately, and I think we will speak about the acute heart failure, the cardiogenic shock, the guidelines, the management, and the daily practice. I would like to invite Dr. Muhammad Abdul Menem, distinguished cardiologist in NMC Royal Hospital, to speak about the management of cardiogenic shock. Please welcome Dr. Muhammad Abdul Menem.
Thank you. So we talk about more about my nightmares in the cath lab, but we didn't talk about the nightmares in the CCU, which we face like cardiogenic shock. So this lady came to our hospital. She's almost 70 plus years old, and she's non-diabetic, ischemic heart disease, cardiomyopathic, mild chronic kidney disease. And she was presented to the ER with pulmonary edema. The ECG show rapid AF with wide QRS tachycardia. And at that time, she was stable regarding the vital signs. So she was given amiodarone infusion, and she was referred to the CCU. When she was referred to CCU, her blood pressure was fine. And at that time, she was cardioverted normally to normal sinus rhythm. But we did the echo, and unfortunately, we found that the echo ejection fraction was almost 17 to 20% with global hypokinesia. And when we dig in Malafi, we found that this is her basal ejection fraction, and she was discharged only few days ago with the same situation from another hospital. So after that, we started the medical treatment till the investigations and the lab came. We decided to treat the situation. Now we are facing non-STEMI because troponin came high, inducing AF and pulmonary edema. There was type 2 respiratory failure and dilated cardiomyopathy with very poor ejection fraction, moderate aortic stenosis, hypertension, diabetes, and at that time also there was some hypokalemia because we gave her Lasix infusion and it was treated. We started the medical treatment for the patient, and after that, unfortunately, the patient again had rapid AF with wide QRS tachycardia. After that also it was treated because the patient was hemodynamically unstable. So we go with the electrical cardioversion, and we found that when we sent all of the investigation that some deterioration happened, and some of the nurses, they found that there is black tear stool. First, we planned to do coronary angio because troponin came high. But after that, unfortunately, when we found black tear stool, so we were not able to do the coronary angio because if we go through BCI, you have to put the patient on antiplatelets, anticoagulation, and this all we cannot give because there is mostly hemorrhage coming in the stomach or wherever. So multidisciplinary team of cardiology, nephrology, gastroenterology, intensivists, we started all to treat the patients, and we infused her with 2 bagged RBCs. And hemoglobin, we found there is drop of almost 2 grams. After all of these measures, patient better and was improved. Then suddenly she had a storm of VTAC and received 8 DC shocks. And again, she was defibrillated to normal sinus rhythm. So it was full night of nightmares. Then again, we hardly convinced the gastroenterologist to do upper endoscopy for the patient, and we were lucky to just ablate this bleeder in the stomach, and she was stable after that regarding the hemodynamics. We decided after that because little bit there was hypotension again and AF again, then she was cardioverted again, so we fixed intra-aortic balloon counterpulsation to keep her blood pressure stable, and we started for sure norepinephrine, and we started all of the medical treatment for her. Again, we bought the CPAP and tried to stabilize the patient. Intra-aortic balloon patient started to be stable, so we decided to decrease the augmentation to 2 to 1. After that, creatinine started to improve because at the first day, creatinine was a little bit increased. Albumin was a little bit low, so we increased the infusion of the albumin, and the Lasix infusion started also, then we decreased it. To summarize and to give impression and diagnosis of the situation we faced, we had a cardiogenic shock precipitated by ischemic dilated cardiomyopathy, non-STEMI, and arrhythmia and anemia. Non-STEMI causing also AF and pulmonary edema, type 2 respiratory failure, and type 2 cardiorenal syndrome. And that also Dr. Hani was talking about, the cardiorenal syndrome. Multi-organ failure, acute anemia, hypokalemia, hypoalbuminemia, congestive liver cell failure. And patient finally, after almost 48 hours, she was stabilized and she was doing fine. And after 2 days, she was discharged and went to Cleveland for another opinion. And they decided also to treat her medically, not to treat her with any intervention like angio or valve replacement for the aorta. So this is regarding the cardiogenic shock. Why it happens? This is the algorithm, and yeah. Usually the cause of cardiogenic shock, either cardiac arrhythmia or cardiac valve dysfunction, cardiomyopathy, myocardial infarction. First, the right half of the screen, this all can cause decreasing in the contractility. The second half, it's about the time. So the diastolic filling is less and the heart rate is less. Whatever, the stroke volume is less or the heart rate is less, all of this will lead to low cardiac output. When we have low cardiac output, we will have decrease of the blood pressure, we will have cold pale extremities, and when we have this all, we will have also more congestion on the right side. The GBP will increase, pulmonary blood pressure will increase, we will have peripheral edema. It will end with progressive also decrease in the blood supply to the brain, to the heart, to the kidney, and it will end with acute kidney injury as if it happened with us. And we will find all of these signs and symptoms of the patient, what happened. So this is the stages of cardiogenic shock from start to the end. It starts with the patient who are at risk to have this cardiogenic shock. These patients usually are patients with cardiomyopathy, ischemic heart disease. All of these patients are at risk to have this cardiogenic shock. Beginning of cardiogenic shock, you will find the patient has some hypotension, but still some tachycardia, but still he's hemodynamically stable. Then after that is the classic cardiogenic shock, and in that stage, you will find the patient, he is more going to the cardiogenic shock with more hypotension, more tachycardia, and he needs at that time your support, either medical with norepinephrine or with cardiac circulatory support. If patient didn't respond, he will go to the tetrawating, which is the same previous stage but not responding to the treatment, and it will end with extremities and pulseless electrical activity, and it will end by the patient, he will die. So this is how to diagnose cardiogenic shock. You will find multiple of parameters that you should search about. You should search in the kidney, like pulmonary kidney function, like creatinine and cysteine C. You will find the beta natriuretic peptides is high, lactates is high. Many of these, all laboratory finding you will find. Regarding the classification and the treatment for cardiogenic shock, if it is classical cardiogenic shock, you should go with vasopressor and inotropes. If it is eovolumic, you should go with fluids. Then you go with vasoactive. We classify this according to the temperature of the patient and how he is wet or cold. So this is the definition of cardiogenic shock according to the most of the trials and European Society. They all agree that the patient is hypotensive, systolic blood pressure is less than 90, and diastolic is less than 60 for more than 30 minutes. They are all agreed that lactate should be 2 or more. And this is the most criteria used to diagnose cardiogenic shock, and the measuring also of the cardiac index, which is not available in all hospitals. This is the trials regarding the treatment of cardiogenic shock. Now, if we can see here, in the shock trial, first trial they did in 1999, there was no significant difference between medical treatment or even intervention. But later, when they did subgroup analysis in 2007 in shock trial, they found better improvement in the survival after doing culprit lesion treatment for the cardiogenic shock. Later on also, there was some mortality benefit when we use epinephrine over dopamine. So now in the guidelines, it is better to start with epinephrine more than dopamine. So this is regarding, and they found also, by the way, mortality benefit in using levosimendan. I think we started everybody to use now levosimendan in our private hospitals and all hospitals. Anybody has experience in levosimendan, Dr. Ahmed?
No, we don't get it.
Why you didn't get?
It's very expensive. You know how much one ampoule?
2,000 almost.
1,800.
Yes, but this is, sometimes it will give your patient chance to live. Mortality rate in cardiogenic shock is very high. So any weapon you have, you should use in this fight.
And in fact, Dr. Mohammed, we use it especially in cardiac surgery when the patient are post-operative cardiogenic shock or when we face emergency situation. The levosimendan advantage is a very powerful tool when you don't give the effect, you don't get the effect from epinephrine and norepinephrine because of the calcium channel sensitization due to the levosimendan. So it's a key factor which can really help the patient to escape the cardiogenic shock in critical situation. So we used to use it. I don't know if Mediclinic we have, but it's not in common use. We use it as a last option, let's say.
Yes, if you dig in the pharmacodynamics and the kinetics, Dr. Ahmed, about the levosimendan, levosimendan is a positive inotrope and it causes vasodilation. So it prevents other side effects of cardiogenic shock like acute kidney injury and help the patient to stop the deterioration of being in multi-organ failure process. So this is the theory. It happens sometimes.
One more thing, Dr. I'm sorry for the interruption, but
Sure.
regarding the expenses, levosimendan, it's only for 24 hours, by the way. You don't keep infusion like the noradrenaline and all those things we used to do in the cardiogenic shock and septic shock. So basically, regarding the expenses, it will not be very much expensive if used for the patient because it has a very long half-life, almost 7 days. You lose it for 12 to 24 hours maximum. And the good thing that it reduces the pulmonary artery pressure, increases the cardiac output dramatically. So I've used it even on kids inside the ICU in cardiogenic shock. And
Yes.
There was dramatic improvement.
So I think we should all now change our practice in cardiogenic shock. We start with norepinephrine and then we should upgrade to the levosimendan after that. So this is regarding the medical treatment of cardiogenic shock. And regarding the also BCI, it is to the culprit region. Regarding, we have the best interventional cardiologist now here in this hall. Let's ask, what do you do in cardiogenic shock? You will do culprit, Dr. Mohammed, or you will do all lesions?
It depends, I think, case by case. It's difficult to, it is not standard. I think the studies have been inconclusive. The shock trial, we used to revascularize everything, but I think that's clearly the wrong thing, because sometimes you cause more injury if you chase non-culprit lesion, cause more kidney injury, more time consuming of the patient. So what I do, I get the culprit lesion done, stabilize the patient, maybe put balloon pump or impeller, it depends if you have availability, and then the other lesions will be done at later stage.
So we'll start with the culprit.
Start culprit, definitely.
The
And that's evidence-based now, the culprit lesion.
The guidelines also say so, the culprit lesion alone. For cardiogenic shock, just do the culprit lesion and then, yeah.
Because there is now coming studies that we should do open everything, not only the culprit region.
No, the culprit shock trial was is just the culprit lesion and leave the rest for later. Because, I mean, it doesn't make sense. If you have, say, for example, occluded LAD, proximal LAD, and you have 80% in the circumflex and 80% in distal right, these chronic, the other two lesions. So you open the LAD. If you want to spend more time with the other lesions, you will give more contrast. The patient would be lying for a longer time on the table. So the complications from the procedure would definitely increase. And the contrast-induced nephropathy is a strong predictor for mortality.
Okay. Then regarding the
Dr.
devices,
Mohammed, I have a question here for Dr. Andron also. Of course, this situation is a very critical situation. Ischemic patient coming with cardiogenic shock, and then we are not sure about his ischemia. We have some high troponin and so on. So do you stabilize your patient first, for example, with Dr. Mohammed, and then you try to get a better situation, and then you go for angiography and then possible PCI, or you take the patient immediately to your cath lab? So what is the guidelines
Yeah,
in this?
it depends on the ECG. I mean, the guideline is clear. If the ECG shows ST elevation, you take to the cath lab straight away. If it is non-ST elevation, then you have time to stabilize the patient. So, but ST elevation means the artery is occluded, then you have to open the artery. That is absolutely mandatory. And we have a problem with ICU sometimes. I had the patient 2 weeks ago, exactly the same, came with a cardiogenic shock, ST elevation. And the intensivist, he wants to stabilize the patient. I said, no, you stabilize the patient in the cath lab. We take him to the cath lab immediately. The minute we open the vessel, his blood pressure improved and was better. But if the patient doesn't have ST elevation, so if there is non-ST elevation, ST depression or normal ECG or tube inversion or whatever, then you have time to stabilize because the artery is not occluded. Unless if they have like posterior infarct, which is different. But if they have TUF changes or ST depression and cardiogenic shock, then you can stabilize the patient. You have few, maybe time to stabilize, hours. Maybe even could be dangerous to take actually the patient sometimes immediately to the cath lab because you don't want, so you want maybe to intubate the patient before you take them to the cath lab. You want maybe to start them on inotropes and reduce, absolutely, whatever you want to do before you take them to the cath lab. But if the ST elevation, cath lab straight away. Whether the cardiogenic shock or post-cardiac arrest. Again, I mean post-cardiac arrest. If the patient had cardiac arrest, with ST elevation to the cath lab. If non-ST elevation, evidence is clear. No benefit for immediate cath lab.
so Dr. Jairam, by the end also we need to know if you have like multi-lesions, which is more than 90%, what you will do after we finish in 1 minute. Then this is the difference between all of mechanical circulatory support regarding tandem heart, intra-aortic balloon. They found that the only one who really decreased the mortality and improved the survival is the ECMO. But we had to put something, so that's why we put the intra-aortic balloon for this patient. This is the stages of cardiogenic shock, as we said. By the way, when you have cardiogenic shock, you should do what we call rush ultrasound. Rush ultrasound, we have one of the best guys who do the ultrasound here, Dr. Fadi. So we should go through the check our bump, the left ventricle and the right ventricle. We should check even the pipes, which is the vessels, the aorta, and we should look to the tanks, which is the inferior vena cava. So when you have cardiogenic shock, you should do all of this ultrasound. And you should search for the all of reversible causes. Here the list of all of our investigations that we should go through to do the correct diagnosis with cardiogenic shock. This is the guidelines regarding using the inotropes we already discussed, and our goals and procedures to achieve these goals and treat our patients with cardiogenic shock. By the end, still it is a little bit challenging, and this is the stages and what to do in every stage. We can go through this discussion later, and let's go to the last 1 minute discussion in this patient. What you will do if you are in my place? The second question, what was the optimal management? And the third question, would you connect this patient to the ECMO? Last question, would you allow for this patient natural death to happen or no?
I think to answer these questions, we need half an hour, not 1 minute. I believe that we have to move ahead with the next speaker, and then we'll keep the question and the answer for this by the end. Thank you, Dr. Mohammed. Thank you, Dr. Mohammed. So next speaker is Dr. Fadi Girgis. He's a consultant cardiologist and intensive care in Mediclinic Alain Al Gawhara. He will speak about the use of CPAP in acute heart failure patient. Please welcome Dr. Fadi.
Thank you. Okay, so let's assume this is not really a pure cardiology lecture. It's some kind of an acute care medicine or acute critical care medicine lecture. So just bear with me the next couple of slides because there's a lot of abbreviations and terms regarding mechanical ventilation, but you have to understand very well. And then we'll just move on to the pleasant part of the lecture. Use this. Okay, thank you. So first, the key points will define the CPAP therapy for heart failure patients. How do we use the CPAP and which patients do they need the CPAP? Second thing will be, okay, even the green is not working.
ايه ده؟ ده مش الريموت يا عم. It's not the one. It's working. لا هو ده اللي شغال. This is the one. It's not the camera. محمد يا عم منعم. يا عم منعم. هو ده بقى الناتشرالنس. وانا بقول لك بص
الأخضر ده؟
هنا يا عم.
الأخضر ده.
This is a sabotaging only.
Thank
so
you.
no-
That's another trick, okay. Okay, so we'll move to the key points. Second key point will be the terms and abbreviations we'll use in the mechanical ventilator, like the FiO2, the tidal volume, all the things we'll go through it. Third thing will be the parameters for assessing the patient's needs for CPAP and the modes of CPAP. So whether we add pressure support or not to the patient, the PEEP, which is the positive end expiratory pressure, different protocols. We'll show everything live on the ventilator. So tips on optimizing successful CPAP compliance. You have to speak to the patient first and tell him in details what we will do. Some patients are claustrophobic and they will not tolerate the CPAP. And at the end, the imaging tools to guide therapy, which is basically I use the lung ultrasound to know if the patient is feeling better or not and is okay to remove the CPAP. First one is the fraction of expired oxygen, which is the FiO2. We know that room air is almost 21% of oxygen. So if the patient is at room air, he is basically at 21% of oxygen. The rest is nitrogen and a little bit of CO2. We have to determine when we hook up the CPAP on the patient, how much FiO2 do we need? Second thing is PEEP, which is the positive end expiratory pressure. This is the basis of the CPAP, which is basically causing non-collapse and stenting of the alveoli, and it improves tidal volume. Continuous positive airway pressure, which is the CPAP, we'll talk about it in details, and pressure support, which we have to use it to the patient as well in order to increase the tidal volume for the patient. So tidal volume, that will be a parameter on the screen of the mechanical ventilator. You have to know that the normal tidal volume basically is between 0.4 to 0.5 liters, which is around 400 to 500 milliliters. There is a very important parameter you have to see on the screen of the CPAP in order to know if this patient is weanable or not, and shall we remove the CPAP or not, which is called the rapid shallow breathing index. It's basically a division of the frequency, which is the respiratory rate, over the tidal volume. So let's assume the patient is taking 20 breaths per minute, and his tidal volume is 0.4. So we'll just divide 20 over 0.4. And if the results is less than 100, that patient is doing great, and you can remove the CPAP at that time. If the results is, for example, 200, that patient is either tachypnic, distressed, or he's not achieving a good tidal volume. So remember this very well. The frequency over the tidal volume. It's a very easy math. Another thing which is the last is the PF ratio, which is a division of the partial pressure of oxygen you get from the ABG over the FiO2. So FiO2 here will be in liters, not in milliliters. So let's assume like this ABG we can see here, the PO2 of the patient or the partial pressure of oxygen is 57. And the patient is on high FiO2, almost 80% on the CPAP. So which is translate to 0.8. If you need the PF ratio, you will divide 57 divided by 0.8. So the results is 70. That means that patient is really doing horrible. That patient you cannot remove from the CPAP. He might actually need mechanical ventilation. The thing that, as you can see here, we said the normal is 400 to 500. That patient had a 70. 70 means that this patient had acute lung injury. He might be in ARDS along with the acute pulmonary edema. So you have to be careful with that patient. By the way, the ventilator can do all these parameters as well. You don't have to use your calculator. It's everything on the screen when you attach the patient. So what does the CPAP do to the patient? As you can see over here that the picture on the left side, the patient on the CPAP mask, the right side without the CPAP mask. Usually there is a negative intrathoracic pressure on the right side. So what the CPAP does is that it gives you a positive intrathoracic pressure, which increases the flow of air and oxygen exchange inside the alveoli. And you can see even on the left one that there is a maximal pressure gradient reduced from 128 to 112. So if you just add 10 to 7.5 millibar or centimeter water pressure, which is a pressure support on the CPAP, this is what you get, a positive intrathoracic pressure, which you need for this patient for support. What about the CPAP or the non-invasive in cardiogenic pulmonary edema? This is what we need to do. When you attach the CPAP or when the patient is in the acute care and coming with intractable pulmonary edema, what happens first is that you increase the intrathoracic pressure by adding pressure support and PEEP, like we showed in the previous picture. And hence, the right side pressure increases and the venous return reduces. And this is why also when the venous return reduces, we cannot put hypotensive or shocked patients on the CPAP because it will further reduces the blood pressure. So you have to make sure that the patient is not really in shock, because otherwise when you add PEEP and you attach the patient on the CPAP, he will have further shock and he will deteriorate. So it's only for stable patients. Which are not shocked. You can add it for sure hypertensive emergency patients. And hence, end diastolic pressure will decreases, stroke volume, cardiac workload, and the work of breathing will improve. And finally, the myocardial oxygen consumption will decrease. So there is basically combined reduction of both the cardiac preload and the cardiac afterload. It's like you're giving an IV ACE inhibitor and IV nitrates to the patient, but much faster. So the results are usually amazing. Mechanical ventilation in real life, like I said, you just have to add the pressure on the ventilator, set the ventilator to spontaneous mode or a CPAP mode. I'll show you in the photos. It will be very illustrative. A millibar is the same as centimeter water. It's different from millimeter mercury. So if you start pressure support, you should start between at least 8 and 12 centimeter water and the high positive end expiratory pressure, which you usually need. So the physiological PEEP of every single patient is 5, except the patients who had a dead space, like the COPD patient, for example. Usually they have auto PEEP, which is high. So for normal patients, the physiological PEEP is 5 millimeter mercury. What you need to do is you have to add a PEEP of at least 6 to 10 millibar or millimeter mercury. We talked about the PEEP or the positive end expiratory pressure. It's like a stenting to the alveoli. So it prevents the collapse of the alveoli. It improves aeration and oxygenation. So the patient improve. Okay, regarding the fitting of the mask, you can see the mask, there is a helmet, there is a connector to the ventilator, there is a filter, PAP filter as well. There's even an inflation valve where you can inflate the mouth of the mask, and there is straps. You have to make sure that you have a very tight seal of the mask, because if you're putting the mask and there is no proper tight seal, that means there is a leak. That means that you're just not doing a proper CPAP, and the patient is not really going to ventilate more, and he will be more claustrophobic, and he will deteriorate more. And you can see that through the ventilator. For example, the ventilator can tell you the amount of leak. Like here, you can see the leak is 36%, and you can hear it by your ears near the mask if there's a leak. So if the leak is more than 10% on the ventilator, this, sorry, 7 or 8 parameters, because this is basically for other mode of ventilation, like SIMV, AC, assisted control. But only for CPAP, you need to know 3 things. You have to determine the mode. That means you have to put the patient on either CPAP or spontaneous. Different vendors, like the Bennett and the Drager, they will have something called spontaneous mode, which is a CPAP mode. Another models, like the Philips, will have a CPAP mode. So the same for both. And then you have to determine the FiO2 for the patient. In the acute setting, you have to put 100% of FiO2 for sure, because the patient will be hypoxic on presentation. Then you have to titrate down the FiO2 because too much oxygen will also be toxic. And that will be reflected by your saturation on the monitor and the arterial blood gases. This patient for sure should be having an arterial cannula for monitoring. Third thing is the PEEP. And like I said, we have to start by at least 5 to 10 of PEEP, because 5 is physiological. Usually in the pulmonary edema patients, you have to increase the PEEP unless the patient has some hypotension, because more than 10 millimeter mercury of PEEP will reduce the blood pressure because it reduces the venous return as well. So you can see here from the ventilator that it's very easy. So ventilation type, you will go for sure for the non-invasive. This is non-invasive, okay? The mode is spontaneous. We will not give SIMV or AC for sure for that patient. This is for ventilated patient through a mechanical ventilation and endotracheal tube. So only spontaneous or CPAP. You will not need this mandatory type. This all actually are preset, except 3 parameters. So you do not determine in the CPAP the rate or the frequency of the patient. He determines it when you attach the CPAP. So the machine, when it shows you the frequency of the respiratory rate, that means that you didn't put this. It's all preset. Tidal volume is a preset. It's not a preset one. That means the patient determines it. So if you find this tidal volume below 300, that means there's something wrong. Then you have to add more pressure support, or you have to make sure there is no leaks. So what if the frequency of the patient went down to 5? So the patient is apneic. You don't have to panic because the ventilator does everything. It will just continue the mode, and it will turn automatically to an apnea mode, which will make sure that the ventilation and the airflow is going directly to the patient without apnea. So the ventilator will do everything for you. One more thing, like we said, we start with 100 FiO2, then we start to reduce gradually. And third thing is the PEEP. This is a very low PEEP for sure. We will never start a PEEP like that to a patient. You need a high PEEP, at least 10, but sometimes I use 15 or 20 even if the blood pressure is really high. It helps a lot with the pulmonary edema. So next thing is, like I said, this is N for the non-invasive CPAP. Everything is preset. You can see on the ventilator, non-invasive here. The weight of the patient, you can just enter the weight, the height, everything, and the ventilator will give you all the parameters. So forget about the flow triggers, all the things. This is not our job. This is not regarding the CPAP. So one more thing as well is the settings. So you don't have to go all through the settings, but there's something very important. Can you see this S? When you see that patient and you're putting a CPAP, S means spontaneous breathing. So a red S means that the patient is spontaneously breathing. If you didn't see that S, that means there's something wrong. And anyway, the ventilator will just make an alarm and will tell you that the patient is apneic. So you can see here from the American guidelines as well, even in stable patients who had heart failure, as you can see here, with obstructive sleep apnea, CPAP is very highly indicated for that patient on a long term. The hemodynamic effects of CPAP in non-invasive, it's very important. So patients were evaluated in a lot of studies with acute decompensated heart failure. And it turned out in the studies that a CPAP of only 10 millibar or centimeter water was applied over 30 minutes in the study. Primary endpoint was change in the ejection fraction and the mitral regurg rate. So you can see that after 30 minutes only, only after 30 minutes of CPAP, the mitral regurg decreased significantly along with the ejection fraction improvement with exacerbation of severe chronic heart failure. So the effect is very fast. It's not like the nitrates or the medications. It's not only oxygen you're giving to the patient. You're increasing the tidal volume, oxygenation. You're stenting the alveoli. You're preventing collapse of the whole airway and the alveoli in order to improve the flow. So a lot of studies were done in the frontiers as well. There was a very good study regarding the HFrEF patients with OSA when you put them on the CPAP. And it was turned out that those patients had significant increase in ejection fraction on the long term when you put them on the CPAP. And even after 1 month of CPAP therapy at home, those patients had an improvement around 10% of the ejection fraction along with the MR. This is the benefits, like we talked now regarding those patients who are on CPAP. You improve oxygenation, you improve cardiac unloading, the lung respiratory muscle function, the work of breathing decreases for the patient. You improve hypoventilation and hypercapnia, and respiratory pattern improves dramatically as well. So we said before that CPAP is contraindicated in shocked patient or severe hypotension. So because like we said, with the PEEP you add to the patient, we reduce the venous return. So that means you reduce the preload further. So we never put a CPAP patient, a hypotensive patient on a CPAP, except if the patient is off inotropes and he's maintaining a MAP around 65 to 70, and this is his normal blood pressure, which is a little bit hypotensive, that means it is okay. But patients who are on high inotropes, I'll get to this in a minute as well, you cannot do that. So this is a very nice slides for a lung ultrasound imaging before CPAP patient with acute pulmonary edema. So as you can see from here, this is a pleural line over there. It's like a curtain. And this is the B lines, confluent artifacts, vertical, goes to the end of the screen. The other slide is the same. So this more than 3 to 5 B lines, it means the patient is in acute pulmonary edema. So what happened with this patient? This is another one, same patient in fact, but you can see there's some nice illustration in the photo here, standstill photo. This is the B lines we talked about, equidistant from each other, confluent and reaching the end of the screen. So this is a patient after CPAP, only 30 minutes after the CPAP. So what do we see here? This is called A lines. So the A lines is basically, you cannot find A lines and B lines. The A lines erase the B lines. When you see this equidistant horizontal lines in the lung ultrasound, that means that the A lines already erased the B lines. That patient is healthy. This lung is quite healthy because there is no B lines anymore. So A lines is something good, B lines is not. So define the weaning of the CPAP. How can you wean the patient of the CPAP? So you just, all you have to do is you reduce the parameters gradually. Decrease the ventilatory support, reduce the FiO2, reduce the PEEP, assist the patient response, make sure there is no sedation, reduce the parameters regularly. So make sure the respiratory rate is not less than 25 and not more than 30. Tidal volume is 5 ml per kg. PF ratio, we thought about it before. If it's very low, that means patient in acute lung injury. Make sure it's greater than 200. And the rapid shallow breathing index over the FT value is less than 100. So alerts before start weaning. Make sure that this process is really difficult for the patient. You have to explain meticulously that he has to endure and tolerate the CPAP mask. Make sure that he's not discomfortly, not feeling well because of the mask. If this occurs, then, and you feel that the CPAP is not working properly, then just go back to the same setting that you had before. And avoid the night shift weaning, because usually most of the staff, nurses, everybody is awake in the early morning, and things can be followed up meticulously during the morning shift, not the night shift. Signs of intolerance or failure of during the weaning from the CPAP. So if the patient, there's no single symptoms, but if the patient still have increased work of breathing, respiratory rate is high, and the patient has still bad chest, crackles, wheezing on auscultation, oxygen saturation is not really optimum, mental status is not well, still on sedation, he's not off sedation completely, blood pressure is fluctuating, or heart rate is not really well, or some cardiac arrhythmia, then you cannot remove this patient from the CPAP. So, tips to optimize the weaning: make sure the patient is not inotropes before you remove the CPAP of the patient, unless he's on a very minimal amount of noradrenaline, like 0.03, for example. PF ratio is more than 200, like we said. FiO2 ratio, you have to reach at least 40%. You cannot wean a patient on, for example, 80 or 100% of fractionated inspired oxygen while in CPAP. That means he will deteriorate and relapse. Make sure the PEEP is less than 8 and preferably 5. So this is live cases for failed weaning. This is a patient with pulmonary edema. You cannot remove this patient from a CPAP. You can see B lines all over. And this is a nice patient as well. It doesn't look really nice. You can see this is the liver. It's a lung ultrasound. This is a liver. This is a diaphragm edge. And this is the spine. This is all the pleural effusion the patient has. And this is a pleura. So you can see the patient had a mix of severe consolidation and pneumonia and pulmonary edema at the same time. So you have to tap this patient before remove from the mechanical ventilation. Sometimes they need even endotracheal intubation and mechanical ventilation. Another patient, this patient has COVID with pulmonary edema. You can see that the pleural line here is fissured, cracked. It's not nice and clean as if the patient in pulmonary edema. So that means there is an infection on top of the pulmonary edema. So that patient is not weanable as well. Vasopressors, like we said, there is high mortality rate whenever the patient is on high noradrenaline more than 0.5 mic per kg per minute. So mortality rate increases whenever the noradrenaline dose increase. So if you have a patient on this small doses, you can still remove and hook away from the CPAP. Otherwise, you cannot wean the patient. And this is another patient, acute severe LV dysfunction. As you can see here, this is acute mechanical complication, probably cordial rupture for the severe mitral regurg. And that patient is not weanable. You have to stabilize this patient before removing from the CPAP as well. Cardiac arrhythmia. You cannot remove a CPAP from a patient and support if there is cardiac arrhythmia. You have to treat this first, meticulously, before considering weaning the patient. This is enough for ventilation today. Thank you very much. Any questions?
Thank you, Dr. Fadi, for an excellent presentation.
Thank you.
The next presentation is by Dr. Hamad Munir, and Dr. Hamad Munir does not need an introduction as such, and he'll be talking on the unusual causes of acute heart failure. Dr. Munir.
Just 5-minute presentation. I will need Dr. Walid, the cardiac surgeon, just to tell me his opinion, because this is already a patient who has already been done. So I'm not gonna give all the slides. So sometimes we face patients with heart failure, and we don't know where is my presentation. كل حاجة الأخضر بقى. أنا دوست الأخضر أهو. جيت أنا أهو. شفت؟ دوست الأخضر أجي أنا. So it's a case. It's a real case. We have it like several years back. And she is a 69 years old female patient presented to other hospital in Al Ain with exertional shortness of breath. Her BNB was 4,370. Her ECG showed atrial fibrillation, been treated in her country as a case of heart failure, kept on anti-failure medication, NOACs, and everything. And despite all the anti-failure at that time, this was maybe like 2016 or something like that. So that time, she was in full anti-failure medication with a very big doses of diuretics. Should be some improvement, but she did not improve at all. So she was seen by a cardiologist, and she had an echo. The diagnosis was left atrial myxoma with severe mitral regurg. So the patient was sent to our facility for removal of the myxoma and mitral valve replacement. Okay, so that's one of the tips that any patient going for cardiac surgery, as Dr. Walid usually do, we have meticulously to do like an MDT meeting between the cardiologist and the cardiac surgeon, and we really look of the indication for surgery, okay? You trust only your eyes, okay? I'm sure that she had echoes with professional people, but for me, well, I trust only my eyes. So even if I am not going to build the echo, but I do the echo myself. I want to see it because this is so important. So she was referred for me for preoperative final echocardiogram, just 1 day before her admission, just only 1 day before her admission. So she had a CT angiogram done in Al Ain, showed what we did. We told her to bring all her CD because this was not the typical picture of mitral annular calcification with severe mitral regurg. The calcification looks like a chunk of calcium. It's not only doesn't look even on the annulus, as if there is something in the muscle itself. So this was her CT, which was done outside. Okay, so we can see here that she has in the mitral valve area, she has a chunk of calcium. I'm going to show it to you. So we had an echocardiogram, and this is what we find. We had a mass lesion. It looks like a mass, so they thought it's involving the mitral valve annulus and posterior commissure, and it looks like that it is a mitral annular calcification, but usually the mitral annular calcification does not come in this picture. So we send her for cardiac CT. We have a dense calcified mass over the mitral annulus. And then we had cardiac MRI was requested. I'm going to show you this. So this is the work of Dr. Ahmed. So we can see here homogeneous, strong delayed enhancement of the mass lesion compared to the dark, completely nulled myocardium, okay? So we dig into the literature, and then we diagnose her with caseous calcification of the mitral valve, okay? So it's like some sort of calcification. It looks like the TB, which is caseous material, but it's not a TB. It's not an infective caseation. No, it is like calcium caseation. So this, it looks very well. Then the discussion started. Shall this patient, after we put the diagnosis, shall go for surgery or not? Dr. Walid, if you have this patient, would you go for surgery?
It's a very difficult question. Yani. We need to have a full picture of this patient. So what about the other investigation you did to prove if it is tuberculous or it is a malignant
TB test
kind
negative.
of negative
TB
test
test,
for
all TB
tuberculosis?
tests negative.
So any test done for malignancy? I mean malignant mass in the heart?
The CT
included?
chest and the CT abdomen she did outside, she didn't show anything. And she has significant mitral regurg. So this calcification or this chunk, we had a significant mitral regurg. And this is actually get her the symptoms. So at that time, there was a lot of debate. Shall we do the surgery or not?
If she has a severe mitral regurgitation affecting, of course, her hemodynamic and producing pulmonary hypertension, and we don't know the cause of this mitral regurgitation, so we have to go for surgery because this is the only way.
No, the cause is this one. The cause is this caseous calcification involving the annulus of the mitral valve. That's why she has this mitral regurgitation. And that time, we looked, us and the radiology and the cardiac surgery, we have looked into the data and we saw few cases like that typical MRI presentation like this one. So mostly we were with the diagnosis of caseous calcification of the mitral valve. I'm going to give some information about the caseous calcification of the mitral valve. But when we look into the literature, it mentioned that we should not, anyway, let me continue and then we'll discuss it then. So this is the mass lesion appears essentially involving the mitral valve annulus with a sagittal gradient echo MRI, notably related to the posterior commission by the arrow. So caseous calcification of the mitral valve. It's a rare variant of mitral annular calcification since most cardiologists are unfamiliar with caseous calcification of mitral valve. It is commonly misdiagnosed as an abscess tumor. That's why she was sent as a left atrial myxoma or infective vegetation on the mitral valve. It appears as a round, sometimes semilunar, large, echo-dense, soft mass with central echolucences seen on both transthoracic and in particular transesophageal echocardiogram resembling a periannular mass. It is located at the posterior annular region of the mitral valve. So the exact prevalence is unknown. There is 2 studies looked through the prevalence of this disease in echocardiographic laboratories and find that it occurs in about 10.6% of the population. Among these cases, we find 0.63% to 0.64%. So it's still, we don't know how prevalent it is. So it is considered to be a dynamic and resolving process. It can resolve spontaneously and transform back to the regular mitral annular calcification. However, it may recur even after surgical excision. Currently, there is no consensus on the optimal management. The current data suggests conservative medical management for the caseous calcification when the diagnosis is uncertain and there is no obstruction to left atrial emptying. So at that time, there was a debate. Shall we go for surgery or not? She go for surgery. So the current indication for surgical intervention include mitral valve dysfunction, either stenosis or regurg, and embolic manifestations, or when it is impossible to rule out the possibility of a tumor. Mitral valve replacement is preferred to mitral valve repair. It should be noted that aggressive debridement may increase the risk of perforation of the left ventricle, and simple unroofing of the cavity would continue to expose necrotic debris to the systemic blood flow. Therefore, a technique of non-everting annular sutures is recommended. Anticoagulation should be considered in patients with caseous calcification of the mitral annulus who present with embolic manifestation. This is after surgery and during the surgery. So it was very clear, okay? And actually, it's been roughly de-roofed, and they try to, you know, like as if you have a
Choke.
as if you have choke and you are, you know, removing. So actually, this patient end with multiple systemic embolization, not embolic, not thrombotic. It's from this caseous material. And actually, she stayed in SKMC for like 6 months, and then she died at the end. So it's a rare case, uncommon case of patients who present with heart failure, and then we find a very strange cause for this heart failure. Thank you. طب حد يناديه يا جماعه من ناديه بقول لك ايه
Yeah, Dr. Ahmed, thank you for your case. I'd like to have an inquiry. You said it's in the literature, no need for surgery. But there is, yeah, unless you have mechanical problem like that.
Yeah.
But there is no proof for definite diagnosis.
Yes. But she had severe mitral regurg.
Yeah, I know. I'm
So you
not.
have
I'm not
to-
arguing
yeah,
against surgery. I am with surgery.
No, we were against.
I am with
surgery.
surgery, not against.
No, we were against.
No.
We were against surgery actually.
But
We as a cardiologist that time.
But no proof for any
know.
definite
But
diagnosis.
after we got this, you know, if you go into the literature, just few information about this thing, and actually we published this case even. So what I'm trying to say that even when we had the MDT, we as a cardiologist, we thought that we can manage the patient medically. She can be pushed with some medication, and then let her, you know, stay what years she's gonna stay in peace.
She could be calcific abscess, calcific vegetation.
Exactly.
So there is no definite diagnosis for
I
that
know.
entity. This is my opinion.
No.
So why do we against surgery? We don't have tools.
Biopsy? How you go biopsy? No, you cannot get biopsy. You have to remove it.
Excision biopsy. you
Because
mean.
there is a mechanical mitral regurg.
You have to do biopsy
You have
only
to do
intraoperative.
surgery.
Only
Intraoperative.
intraoperative. No.
And when they open and they found this is for them as a cardiac surgeon, according to the surgeon that time, that he said that it's typical caseous calcification.
No, my opinion in the beginning, we don't have definite diagnosis for that. So surgery is indicated. This is my opinion. This is what I'm trying to say. You got my point?
I would like just to say that this embolization of the caseous material could occur without the surgery. I mean, with the presence of this mass, it will detach and it will embolize. And the only way to diagnose this patient is to go intraoperative and remove this mass. I think this was and we remove this mass, and then we can get a diagnosis. Otherwise, you cannot get a diagnosis. Of course, it is a very rare case, and I never saw this in my life. Over 28 years of cardiac surgery, I never saw a patient of caseous tuberculosis, most probably tuberculosis infection, including the mitral valve annulus. But the surgery was the only way to do it. The complications is very, very common to happen. Embolization can even happen without the surgery. So I think the right way was done for this patient, and unfortunately the result was not.
Suppose this patient did not have such a mass was there, but she did not have heart failure or mechanical complication. This will just be left alone like that.
Yeah.
She will never come to him. No heart failure.
No, suppose you incidentally detected such a thing on a routine.
There was another patient that we actually had very recently that presented with a stroke, actually. And as part of the workup for the stroke, we discovered a very similar mass, but it was actually extruding under the inferior surface of the aortic valve. So it was very large, basically a periannular caseation mass, all the way around, all the way anteriorly. And actually, this patient was before Dr. Walid joined us, so that we had a gap where we didn't have a cardiac surgeon. She went to Gopal and the team in Cleveland, and this is what they did. They did a complete resection, and they had to do a mitral valve repair, and it turned out to be just that, just simply caseous calcification.
One of the meetings it was presented.
Yeah.
That case was presented in one of them.
But the risk of during the surgery, the risk of embolization is very serious.
But if that is left alone,
So it's the same idea as having endocarditis, right? If you have a large mobile mass that's more than 1.5 centimeters, then surgery is indicated. So can we have the slides, please? Slides? Slides. Yeah. Thank you. Okay. We're moving faster. شغال. بدي أقدر. Okay, so actually this is a case, a very interesting case. It's a very sad story actually. It's a tragic case where we're going to look at a case of severe pulmonary hypertension that was neglected for many years and with severe RV failure presenting cardiogenic shock. I actually put together this presentation with my good friend Ahmad Taha, who is a specialist in Cleveland Clinic in the critical care cardiac anesthesia department, and myself. So I actually went to medical school with Ahmed, and he's not here, but I have to give a little pitch. We and him went to medical school during the first Gulf War in Ain Shams University. So, and we worked with Dr. Walid also in SKMC. So I have no disclosures related to this presentation. So pulmonary hypertension, as you know, is a severe disease that's progressive, and we're talking about what's called pre-capillary pulmonary hypertension. Its ultimate endpoint is death due to right-sided heart failure. So the classifications are multiple. There are many different types. The types that we are generally concerned about are these. Idiopathic and heritable conditions are part of that. It's quite rare, but of course when it's missed, it has its inexorable course. These patients on group 1 are going to be on medical therapy and are candidates for lung transplantation. Patients with chronic thromboembolic disease get surgical endarterectomy, or now there's something called balloon pulmonary angioplasty, which is multi-vessel angioplasty of the pulmonary vessels, as well as pulmonary hypertension therapies. Too many animations. Okay, so we discussed this in the previous talk. So what I think is very important is this thing called the death spiral. When you have pulmonary hypertension and you develop right ventricular failure, what's going on here is a very adverse pathophysiology. So you start with this point of increased right ventricular wall stress, adaptive hypertrophy. The septum starts to shift, and remember, the right ventricle gets about 50% of its cardiac output from the septum, not from the free wall. Worsening tricuspid regurgitation, which means the preload and the afterload are going to start changing. Ultimately, the right ventricular output can decrease. Now, you can try treatments here at this stage. The earlier you start, the better. And you have pH-targeted therapies, diuretics, and oxygen. Now, as the right ventricular cardiac output decreases, the left ventricular preload decreases too. So you have a double hit on the cardiac output. You see, it basically is a biventricular problem starting from the left ventricle. The overall systemic cardiac output decreases, coronary perfusion decreases, and then you have overt right ventricular failure, where you have right ventricular wall ischemia. And this can actually happen in a very progressive manner. This is called the death spiral, and it's very important in critical care to make sure you don't reach anything beyond this stage. So this is sort of a classification of pulmonary hypertension. The guidelines have changed. Now, a pulmonary artery pressure above 20 is considered abnormal by right heart cath, mean. And pulmonary vascular resistance, typically in you and me, is about 1.5 Woods units. So as the PA pressure increases, the pulmonary vascular resistance is increasing, you're going to get PVRs increasing further and further. More than 5 is very significant. So in severe pulmonary hypertension, there's a phenomenon called uncoupling. Uncoupling means that the right ventricular work is no longer being delivered into the pulmonary artery because of very high resistance. So the right ventricle is basically pumping against itself. A very similar situation like aortic stenosis. A fixed cardiac output develops, and then the right ventricle is not able to adapt, unlike the left ventricle. So patients can have symptoms from a very early stage, but they decompensate in this middle era, and then they decline and decompensate even faster. So the key component here is the pulmonary vascular resistance continues to rise with time. That's why it's a progressive disease. Now, patients can have symptoms or have very little symptoms until this happens. And once the cardiac output drops, then you're in bad shape. This is really a problem where the pulmonary artery pressure and the cardiac output start to come back. And unfortunately, I would say in the registry, we have almost 490 patients with pulmonary hypertension. Almost all of them are in this advanced stage of disease. So what is uncoupling? It's a physiological problem where the pulsatility of the ventricle is not resulting in any kind of forward flow. So look at these pressure volume curves. As you become more and more advanced and the volume is greater, it's not able to generate any further resistance. The reason for this is, as I mentioned, the septum generates most of the force in the right ventricle, not the free wall. The free wall is very thin. It's maybe 2 or 3 millimeters. So all of the force is coming actually from the left ventricle. And as it starts to dilate and push this way, you lose almost all of the forward flow that's going in. How can you know that without a right heart cath? Fairly simple. You can look at a TAPSE. So the TAPSE to RVSP, or the SPAP ratio, is a very easy measure of uncoupling, right? If it's less than 0.4, i.e. the TAPSE is low and the pulmonary artery pressure is high, this is associated with new onset systolic dysfunction. And this also looks at the end systolic elastance. These are more complex hemodynamics. But the easy one is look at the TAPSE and divide it by the RVSP. And if it's getting lower and lower, you know the patient's getting worse. And this is not a situation you can afford to wait too long. Now, right heart cath is essential. Right heart cath, I've mentioned it 100 times this week, and this is really an important point. You need to do the reactivity testing, and you need to use it for initial assessment. What are the treatments that you use? We use combination therapies. Combinations include prostacyclins, nitric oxide pathway, and endothelin antagonists. The preferred endothelin antagonist now is macitentan because it's a endothelin 1A and B antagonist. It blocks all the endothelin pathway. Ambrisentan, while it's cheaper, only blocks endothelin A and therefore leaves 50% uncovered. It's like the difference between a RAS blocker and an ARB. So this is a very unfortunate case. It's a 30-year-old female who's actually a physician. She's a female physician living in Dubai for the last 30 years. She was born in Dubai. She's from India. And her parents, one of them is a physician as well. And she's actually known to have hereditary hemorrhagic telangiectasia. She had genetic testing type 2 basically almost 9 years ago, and was known to have pulmonary hypertension and hepatic AVMs. Unfortunately, over the last 8 years, the patient was on what medication? Low-dose sildenafil, 25 milligrams TID, erectile dysfunction dose, ridiculous. And by the time she came to see me, I actually saw her one time in the clinic. Her JVP sitting in the chair was at her ears. She has pulsatile liver, and she has massive lower limb edema. And we admitted her literally directly from the emergency room to the ICU. So we gave her an inotropic dose, and we sent her home. She ended up in the hospital, the Dubai hospital, approximately a week later with worsening right-sided heart failure and CKD. So we actually transferred her hospital to hospital and started her on intravenous treprostinil infusion, inotropes, and diuretics, and she had to have repeated paracentesis due to abdominal distension. So this is basically end-stage pulmonary hypertension, and therefore the patient would need to have a transplant. So this is her echo. If you can take a look, the LV is completely compressed by this massive right ventricle. And as you look here, you'll see how severe the tricuspid regurgitation. There's almost no left atrium. It's completely collapsed, and her right atrial pressure was 22 millimeters of mercury. So looking through this pathophysiology, it's hard to see how this patient was not referred to a PH center, even though she's a physician with good insurance and a very well-educated family, and why she wasn't on more treatment. So this, I think you can see the TR here is about 93. The right atrium is massive, and the IVC is 3 centimeters non-collapsible. Very advanced disease, unfortunately. So this is her right heart cath, and she actually had never had a right heart cath. I asked her 4 times, did you have a right heart cath? No. So she had genetic testing and never had a right heart cath. It's extremely sad, this case. So her pulmonary artery pressure is 73 millimeters of mercury, and her aortic pressure was 100/60. So therefore, she has suprasystemic pulmonary hypertension. Pulmonary capillary wedge pressure of 21. Now, I told you before that the wedge pressure should be less than 15. Why is it elevated? Because now she's in the phase of forward failure. There is no cardiac output going forward. The left atrium is being compressed by the right atrium, so you now have left-sided failure as well. The pulmonary artery saturation, the mixed venous, is 54%. And her cardiac index is 1.9 liters per minute per meter squared. So she is overtly in cardiogenic shock, okay? And her pulmonary vascular resistance, 15 Woods units. As I mentioned, 1.5 is normal. It is 10 times higher than normal. We did give her nitric oxide. There was a very minimal response. It has to drop below 40 for this to be positive. However, because of the slight improvement, we knew that she had some reserve. So we knew there is reserve, but not reversibility, right? That means this is a patient who could respond to a lung transplant. Because really here the question is, do you give a heart and lung or just the lung? Usually that means the right ventricle can recover. So in case you're not familiar, this is the PA catheter that we place at the bedside, thermistor. This is the pacing port, this is the distal port, and this is the balloon, and this is the right atrial port. So does she have pulmonary hypertension? The mean over 20, of course. Is it pre-capillary or post-capillary? By definition, it has to be less than 15, but here this is a very advanced form of disease, and you know this is pre-capillary because of hereditary hemorrhagic telangiectasia. It's one of the form of hereditary disorders. And what's the cardiac output? Of course, index is the cardiac output over the body surface area, and less than 2.2 is a low perfusion state. She's already 1.9. How severe? This is very severe, but more important than the pressure, it's the cardiac index and the PVR. So mildly elevated, if the cardiac index is low, this means severe pulmonary hypertension. Why? Because it can no longer generate any forward pressure. So a false pseudo improvement is a bad sign as well. So we did vasoreactivity testing in idiopathic, heritable, or anorexogen, and the definition is as follows. Drop more than 10%, less than 40 millimeters of mercury, no increase in wedge, and a significant increase in cardiac index. Of course, she's in shock. You're never going to give this patient a calcium channel blocker anyway, but this is a way to look for reserve. The other thing is if you have patients with heart failure and preserved ejection fraction on high doses of diuretics, you can have a falsely low wedge pressure, right? So you have a 65-year-old with a wedge pressure of 15 who's on high dose Lasix, your wedge pressure can be false. So this is where you give fluid challenge or exercise. So this is the concept of coupling. It's a difficult concept, but I want you to just think about this. If the right ventricle function, represented by TAPSE, is low and the pulmonary artery pressure is high, what does this mean? It means that there's a decreased afterload reserve and it's not able to forward flow. In any case, if you look at the statistics, if you take this number, anybody can do this in your echo lab, the mortality is basically almost 40% higher, and this is in 1 year. 1 year mortality. So let's pay attention to the TAPSE because this is a major marker and everybody can measure TAPSE. It's not a complicated measure. So how do you solve this problem? Now, this woman is in cardiogenic shock. It's a young female physician. Everybody was very emotionally attached to this case. So we can use inotropes. However, they're typically arrhythmogenic, are not often tolerated. Now, milrinone or dobutamine at low dose can be used in patients after maximum medical therapy. Now, ECMO is a robust option. However, it's only going to be if it's a bridge to transplant, right? Because there's no outlet now. So this is the patient's RV function. And you see how dilated it is and how the septum is now flat in the center. And again, there's some more images, this to show you the same idea here. And there's, as you see here, there's very slow, there's almost sludge in the right atrium, smoke in the right atrium. This is a very important idea. You actually should use the right ventricular strain. If you look at RV strain, it can give you a very good component of global longitudinal strain. So when you have a cardiac index less than 2 and a mixed venous O2 sat less than 60% or a pericardial effusion, this is a patient who has a mortality. This has been changed now. It's actually 20% in the next 6 months. And the consensus treatment now is this is a very high-risk patient and needs to go to initial combination using intravenous prostacyclin analog. Before that, she would have been a candidate for oral combination therapy, but of course, it's a little bit too late. So what's the outcome in acute right-sided heart failure? In patients with pulmonary hypertension who had acute right-sided heart failure, the urgent death or urgent bilateral lung transplant was seen in 34 patients. So this is ultimately because they don't even survive the waiting list, right? Otherwise, they would have been able to get on the waiting list longer. And in these patients, this is 46 patients who were enrolled first ICU admission, 27 patients were discharged from the ICU, 30% died within 3 months of RV dysfunction. So this is a lethal complication, and we don't have enough resources to transplant everybody, and the waiting lists are longer and longer. So the key component that I wanted to summarize here is that when you have acute decompensated pulmonary hypertension leads to right ventricular shock. Once in the ICU, the mortality is 40%, and if they survive, 30% mortality. That means within the next 3 months, 70% will be dead, okay? The risk factors are including also when you have acute right-sided heart failure, including high respiratory rate, low sodium, kidney dysfunction, and severe TR. As you increase the inotropic support, the mortality actually increases. It's not caused by that, it's because the RV has basically failed, because now it's progressing as if it's left ventricular dysfunction. So we had very few hours to make this decision, right? This is a patient literally at death's door. She's talking to you, she's very educated. Doctor, can you help me? Okay? Literally, we had to make this decision at the bedside. And this is literally how severe the tricuspid regurgitation is. There is no forward flow. This is actually laminar flow. You see that? All of the flow is going backwards. Nothing is going forwards at this point. So how do you solve this problem? How can you mechanically support the right ventricle? This is another very complex issue that requires a lot of surgical innovation and technique. So you have to insert a pump and also a membrane oxygenator, right? But what if you put the blood back into the lung? What's going to happen? The pulmonary vascular resistance is very high to begin with, right? You're going to overload a highly loaded circuit. So you have to come up with fairly creative solutions. And these are the solutions that have been proposed in the literature. So you can do indirect RV bypass by putting the patient on VA ECMO, right? That's only going to unload to a certain extent, but ultimately you're going to end up overloading the ventricle again. The flow will ultimately have to come back to the right ventricle. So you have this thing which is called Impella RP. Unfortunately, we don't have it. This is a right-sided Impella. The tandem RVAD takes the blood in this direction from the right atrium back to the PA and pumps it this way. But again, this is loaded with a lot of thrombosis and obstruction. And this is a very interesting device called the Protect Duo, which actually works peripherally, and the balloon is actually centered on the pulmonary artery. So these are different surgical approaches to the problem. And this is what happens if you connect an RVAD to the right ventricle, right? The main problem here is that the pulmonary vascular resistance is high, and it will cause occlusion alarms of that. It's not going to work. Dr. Waleed knows exactly what I'm talking about. So the other options are what's called a pumpless PA to the left atrium. So you insert an oxygenator between the pulmonary artery and the left atrium. This is called the Nova Lung device. It's only available in Germany. And you can also do veno-venous ECMO, taking a systemic vein returning to the right atrium. This is RA to PA ECMO. All of these require fairly intensive surgical approaches. So this is one complex way to do it. You basically clamp the pulmonary artery. You see that? You're going to take the outflow graft, take this into the pump, and this is all surgically inserted, right? And you also have to have a probe to see how much flow you're going to have here and flow here. You're going to redistribute the flow deliberately in order to get the blood to come out of the pulmonary artery back into the systemic circulation and get oxygenated. I don't know if you can see anything more complicated than that. I'm going to show you actually a picture. So this was the Protect Duo clinical trial. In patients with pulmonary hypertension, the survival was fairly miserable. So it's not good, but it's better than zero. Again, as I said, the mortality here is almost 70%. Okay. So this is the idea behind these systems. So you're going to take oxygenated blood returning through both lumens back up into the pulmonary artery, and also it's going to go into the left atrium and go back and recirculate. You have another flow here that comes from the inferior vena cava, which goes to the membrane oxygenator. So I don't know if you can see all of this, but I'm going to try and explain this to you here. There are two outflow limbs that are coming through the neck. There's two inflow limbs that are going through the chest. This is an open chest type of ECMO. And you have flow detectors on each one of these in order to regulate the amount of flow exactly. So you have to make sure this is being done basically hour by hour by the perfusionist. Basically, the perfusionist is sitting at the bedside and not going to your operating room. So using this strategy, we were actually able to improve the renal function, recover the liver function, and was able to wean off sedation and ambulate without progressive RV failure while tolerating fluctuations of intrathoracic pressure and dynamic pulmonary hypertension. So the reason why this patient ultimately expired, because on ECMO, it doesn't fix everything. So we ultimately had a bleeding event while she's on ECMO. You have to be completely, very heavily anticoagulated. And she developed severe colonic bleeding that could not be controlled. 6 different attempts by the intervention radiologist, and the bleeding was just exsanguinating. So unfortunately, it was hemorrhagic. And remember, this is a patient with hereditary hemorrhagic telangiectasia who has multiple hepatic and venous AVMs to begin with. So while we describe this tragic case, it's really only for us to learn the main 3 messages here. If you leave these patients on untreated, undiagnosed, this is what happens. The endpoint is regardless. And again, we have a lot of different treatment options. They're very complex, especially in the shock patient with RV failure. It is complex, but not impossible. And this RV to PA mechanical support with a partial algorithm with a lot of input from at least 12 different doctors could have kept the patient alive, but unfortunately the other comorbidities came in instead. So thank you very much.
So I think the take-home message, try to look for patients with pulmonary hypertension early, because whatever early we can treat, and then earlier we can have more. Dr. Muhammad.
Dr. Hani, what is this devastating case? I think it's really very sad case, and I would imagine the whole team was heavily involved in that case. I think so out of these options you mentioned, all these invasive options, although I don't have any experience with the RV Impella, do you think RV Impella would have been a reasonable option, the least invasive option?
So we actually tried to get Impella RP from the company on a rapid basis. Physiologically, it makes sense because it's going to remove the flow backwards and improve forward cardiac output. So like it does on the left side, it actually improves the pressure-volume relationship and restores coupling. So it physiologically makes a lot of sense. And in terms of the invasiveness of the technique, it would have been a lot better. Unfortunately, we don't have Impella RP. We barely have the Impella 4.0, right? So I think these options of mechanical support are becoming significantly better as tools, but we still have to remember any kind of mechanical support has to be anticoagulated. This is the biggest problem. The Achilles heel is very intense anticoagulation. And this girl was on a transplant list. She was expedited for a transplant. Everything was done. We were just waiting for a donor, and then the bleeding was just completely uncontrollable. I cannot explain how many times she was taking this poor woman to the intervention radiology lab. They'd find one bleeder, would stop, another one. So, and then she went into DIC, and it became a hemorrhagic shock at that point. So, yes. So I think that's it. I think these smaller devices are clearly less invasive and allow us to pull the trigger early. This whole setup took hours to do. Hours. I'm not kidding. Maybe Dr. Walid can also give us his perspective on these complex ECMO devices.
Are so complex cases because we are dealing with primary pulmonary hypertension. It is a microvascular disease, and the only solution will be a lung heart transplantation. The main point is how to support this patient to reach the point of transplantation. I believe that a VA ECMO can solve the problem of this patient, but because of this telangiectasia is also a problem, so this patient will be very liable to fatal bleeding like what happened. So I believe that early detection, early diagnosis would help. If she developed a severe heart failure like what happened, so she has to go for VA ECMO, and then we have to arrange for lung heart transplantation as soon as possible if available. She's a doctor, and I think this is very sad that she didn't detect her disease very early.
Yeah. Yeah.
Me again.
Yeah. Thank you,
Me
Dr. Hani,
again.
for the excellent presentation. We'll go to the
Huh?
next.